Welcome yet to another case, guys. If you didn't check out the previous case, be sure to check it out. Link in the description below. Okay, so today we are having a new case. So it's case number 2 in the neurology series. We have a 19-year-old female who's a referral from the local hospital. She has a background history of chronic gastritis. Remember, chronic gastritis is a long-term condition in which the mucus-lined layer of the stomach, what we call the gastric mucosa, is inflamed or irritated over a long period of time. She is also known with asthma, so she presents to you, doctor, I'm having progressive inability to walk for over a year now. So on past medical history, remember she's non-asthmatic, so she's on beclomethasone, which is a steroid commonly used in asthmatics. She's on salbutamol, which is a sympathomimetic, or the beta agonist, which is used to bronchodilate in case he needs to breathe. She has no significant prior admissions. She's actually on other 3 drugs, one being omeprazole, which, remember, it's a proton pump inhibitor which reduces the amount of acid your stomach produces. Then she's also on Clexane, which was started at the local hospital before they referred the patient, simply because, remember, Clexane is a low molecular weight heparin which will treat or prevent blood clots. And since she could not mobilize, this is to give it as prophylaxis. And finally, she's on what we call Adcor Myogel, okay, which is a suspension antacid that relieves heartburn. On social history, perhaps to add, she's a grade 11 learner, she's single, she has poor socioeconomic status, she's a non-smoker and a non-alcoholic. On examination of the patient was awake, the patient was alert, but there were obvious inappropriate facial grimaces, and most importantly also the patient appeared to be mute. He didn't want to speak. On vitals, the blood pressure was 117/72, pulse rate of 73, saturating at 97% on room air. She was also apyrexic at 36.7 degrees Celsius. On neurologic examination, we started with the higher centers. Although not fully examined, the patient appeared to have altered behavior. One of the ways that we saw is that she appeared to have mood lability. At one moment, she's very happy and jolly, overexcited. At another, is not speaking, is very angry, and appeared to be very irritative. Otherwise, the language and memory was intact. On examination for meningism, there were no signs that were obvious for meningism. Cranial nerve examination was grossly intact. On motor examination of the arms, on inspection, we could not appreciate any obvious scars, there were no wasting, there was no involuntary movement, no fasciculations, and no tremors. However, there was an obvious abnormal posture. Both arms appear to be externally rotated, which will imply that the patient has weakness. And also there was obvious flexion of the fingers. On examination of the tone was surprisingly normal. No spastic catch. Remember, upper motor neuron lesion causes spasticity, lower motor neuron lesion causes hypotonia. And so in this instance, tone was not helpful for localization. On power examination, we started on pronator drift assessment, what we call testing for subtle weakness. Remember, a typical pronator drift, you see it typically starts distally with fingers, then it spreads proximally, then you see slow pronation of the wrist, then slow flexion of the fingers, then slow flexion of the elbow, which we do not appreciate in this patient. On examination of the power, there was so unusual in such a way that in an instance that there were actually daily variation. At one moment it's 0/5 in all muscle group. At some point in some muscle groups it will be 3/5. So there was no consistent pattern in all the muscle group. But one thing was for sure, the arms were weak. On assessment for reflexes, the biceps were found to be actually brisk, as you are seeing in the video there. And then we moved on to the tricep reflexes, which were also found to be quite brisk, as you've seen in the exaggerated twitch of the muscles. When we moved on to brachioradialis reflexes, we could see that the supinator reflex has been exaggerated, and so it's brisk. And finally, we moved on to C8T1, which was also increased. And then we did some reinforcement reflexes, which also showed that it is actually brisk. On sensation assessment, we did a pinprick examination. There was a glove and stock-like pattern of sensory loss extending all the way up to just before the shoulders. Proprioception was grossly normal. On leg examination, on inspection, there was some mild wasting, which we may not be so sure. However, there was an obvious abnormal posture of externally rotated legs, implying that there is weakness. Otherwise, no other abnormalities were appreciated on inspection. There was normal tone examination in both limbs. However, when you moved on to the power, there were daily variations, some ranging from 0 to 3/5, with no consistent pattern in all muscle groups. Reflexes was an interesting part of the examination. The knee jerks at the knees, the reflexes were grossly brisk. Ankle reflexes were also increased with visible clonus on both sides. And thus, that grades the reflexes at 4+. Remember, hyperreflexia is a sign of upper motor neuron lesion. The Babinski was negative on both sides. Sensation exam also revealed a very interesting finding. There was a sensory level to pain at around T10. However, proprioception was intact. Gait and coordination could not be assessed due to weakness. The rest of the systems were unremarkable.